My name is Dr. Jodie Guest. I'm an infectious disease epidemiologist and professor and senior vice chair in the Department of Epidemiology at Rollins School of Public Health here at Emory University. I have led Emory's COVID-19 outbreak response team working in some of the hardest hit areas of the state of Georgia for the past 3 years. And I'm the host for Emory's COVID-19 videos, where we have covered the numbers and the changing information and guidelines since the onset of the pandemic. Today, I'm very pleased to be joined by my colleague and friend, Dr. Carlos Del Rio, to talk about the end of the public health emergency declaration that ends today. Dr. Del Rio is a distinguished professor of medicine, epidemiology, and global health at Emory, and is the interim dean of Emory University School of Medicine and the interim chief academic officer at Emory Healthcare. Welcome, Dr. Del Rio, and thank you for getting together with me again today.
Happy to be with you, Jodie. It's great to do one of these again.
Thank you. So today, May 11th, 2023, marks the end of the federal COVID-19 public health emergency declaration, which was initiated in January of 2020. Dr. Del Rio and I have done more than 50 videos together talking about COVID-19 in the past 3 years, and it seems fitting that we're here together again today to discuss the end of the public health emergency and what that means and what that does not mean. So, the public health emergency allowed federal government to freely provide COVID-19 tests, treatments such as Paxlovid, and vaccines. All of that changes today, although there are some mitigating factors for how it changes for everyone. Medicaid beneficiaries will now have to pay a portion of the cost of at-home COVID-19 tests and for COVID treatments. People with Medicaid coverage will get cost-free vaccines and COVID tests when ordered by a clinician, but they may have to pay out of pocket for at-home tests. We are going to be talking through the idiosyncrasies of who will have access and who will need to pay for things after today's declaration ending. So as of today, really what's happening is COVID-19 will now be covered in the same way as many other conditions. So let's start with a few numbers. We are now averaging a little over 1,000 deaths from COVID-19 a week. As a comparison, at the height of COVID-19 associated deaths in the United States, which was the highest on January 21st, 2021, we were averaging more than 3,000 deaths a day, almost 24,000 deaths a week in the United States alone. Since April 12th, we are seeing fewer deaths a week from COVID-19 than at any other time in the pandemic since March of 2020. So this is great news. While not everything has gone smoothly, it is still true that the United States has mobilized and sustained a historic response to COVID-19. There is an edict that pandemics begin with a bang and end with a whimper. So, Dr. Del Rio, we're going to start there. As a nation, we find ourselves at a different point in time in the pandemic. We have a lot of tools and resources we didn't have 3 years ago to better protect ourselves and our communities. Is this our whimper?
Well, it is. In a way, I think we need to be happy. We need to celebrate that we are where we are right now, and we are where we are because of several things. But primarily, science has helped us. Vaccines were developed, vaccines were rolled out, treatments are available, testing is available. We're in a very different place than we were when the pandemic, when the emergency declaration, public health emergency was first declared back in January of 2020. The fact is that today we have a large number of the population in the U.S. who has either been vaccinated, been infected, or both, and as a result of that, we have what has been called an immunological wall that puts us in a very different situation with the virus as we were before. So there are some good news, as you said. Deaths are down. They're not down as much down as I would like them to see. We're still seeing about 1,000 deaths per week. I would love to see down to less than 100 deaths per day, so maybe 300 to 400 per week. We're still seeing some hospitalizations. The good news is at least a lot of people have been vaccinated. We have lots of people vaccinated, but CDC recently said that in order to be updated, you need to have received a bivalent booster, and we only have about 17% of the total U.S. population who has been boosted. People over the age of 65, which are the ones that I'm most concerned about, only about 42% of them have received their first booster, and CDC and FDA are telling us now that if their booster was more than 4 months ago, they should receive a second booster. So my concern is that those people over the age of 65 are I'm the ones that I'm most concerned about, because they are the ones that have not been boosted, and they're at high risk if they get infected of ending in the hospital or dying. So we have, good news, and we have not so good news.
So let's stick with vaccines for a second. There are some things that will really shift with the ending of the public health emergency declaration. And one of them is access to vaccines. So let's talk through how we're going to be able to get our vaccines. Right now, my understanding is that as long as there are vaccines available through the government in the United States, everyone will continue to receive vaccines for free. Is that your understanding as well?
That is correct. In fact, as far as vaccines is correct, nothing changes tomorrow. Today, tomorrow, it's exactly the same. You're not going to notice that there was the end of the public health emergency. As long as there is, government bought a lot of vaccines. Vaccines are free regardless of who your payer is, as long as the federal vaccine supply lasts. Once they're no longer available in the federal supply, then your private insurance will have to pay for it. Medicaid, Medicare, there's some provisions to try to do that. And for the uninsured, the White House has has an initiative that through December of 2024, at least for now, we're going to still be free for people who have no way of covering. So at the end of the day, vaccines don't change in a major way. And vaccines will continue to be free once the supply runs out, thanks to the Affordable Care Act and other laws enacted by Congress.
So that's great news. And we do want to be really clear, the vaccines are still an incredibly important part of our efforts to keep people from dying from COVID-19 on a daily basis in the United States and across the world. Let's move to COVID-19 tests. There's actually a bit more that will change about access to COVID-19 tests. And I'm going to split this up into two groups. So first, let's talk about at-home tests, which are our COVID-19 antigen tests. As of today, there are groups of people based on the way you receive insurance or have access to insurance who may no longer see COVID-19 tests at home covered and have access to get them for free. Can you tell us more about that?
Yeah, the free at-home tests are going to depend on who your insurance is. Some of the insurance companies will continue to pay, some will not pay them. The Medicare, traditional Medicare, is no longer going to cover it. If you got Medicaid, you get free testing through September of 2024. And if you are uninsured, you have to pay out of pocket regardless of where we are right now, whether it's at home or at a clinic. So, and when you go to the pharmacy, I just stopped at a CVS, in fact, and an at-home test can cost you anywhere between $20 to $40. So that's for a pack of 2 tests. So it's not cheap, and it's something that I think is going to be a big difference. Now, as far as a doctor order, a laboratory order by a healthcare provider, your private insurance will cover it as far as part of an outpatient visit. Medicare will cover most of them. Medicaid will cover most of them. Again, the uninsured will have to pay for it, and those tests could be in the hospital could be particularly expensive. So that would be different. So yes, the testing situation is a lot more confusing, and is one that we're going to have to get used to. And it's very unfortunate because in many parts of the world you can get tests for a lot cheaper than you can get them in our country.
And the PCR tests, are they now going to have to be ordered by a clinician in order for you to have access to them?
My understanding is that yes, you will have to get ordered by a clinician in order to have access to it.
And from an epidemiology perspective, we already know trying to count the number of cases of COVID-19 that we have a day is really complicated and not very easy to do these days because most people are using at-home tests. Now this is going to be another barrier for people to get PCR tests, which are the data that are most likely to be reported to the CDC. So again, we need to be really careful about how we interpret the numbers that are being shown with tests that are being provided as data to the CDC.
Well, but as you know, one of the things that does get impacted by the end of the public health emergency is surveillance, right? Is tracking, right? Because states will no longer be required to submit their data to CDC from laboratory testing. And therefore, not only is that we're doing a lot of home testing, but even the lab testing is no longer going to be states are no longer going to be required to report that to CDC, and that has a significant impact. But there are things that CDC is doing and has been working on to get us data, and one of them is obviously wastewater surveillance. And wastewater surveillance is a new way to track the virus, and it's being implemented nationwide. And I think wastewater surveillance can really give us a good idea of what's happening in the community and where the virus is going. Hospitalizations are still going to be tracked by CDC through a different reporting mechanism, and so are going to be deaths. So there is going to be some data, but surveillance is going to change from what we know right now.
Absolutely. And I'm glad you brought up the wastewater surveillance. It's really one of the most remarkable advances that we've seen that has happened during the time of this pandemic, to be able to use that. And it's great that that's going to continue, and perhaps even be able to broaden what we can use wastewater surveillance to help us track across this country.
Oh, absolutely. And, it's not just a COVID, wastewater surveillance is now being used. We were able to pick up an outbreak of polio, and it's being used for monkeypox. So wastewater surveillance is really sort of I look at it as an early warning system of spread of viral diseases in our communities.
And we're going to have to get used to looking at these data, because this is really going to be some of the best data we're going to have going forward.
Absolutely, but again, it is a remarkable advance, and I think it's something that what we're all going to have to learn how to use it, how to make inferences from it, and how to try to understand what that means at the community level.
Absolutely. Before we move on from the changes that are happening as of today with the declaration ending, let's briefly touch on treatments such as Paxlovid, and what will remain. They will remain free as long as supplies last. So very much like vaccines. After that, what will happen?
Well, so if you have Medicaid or CHIP, there are three through September of 2024. If you are insured, after that, your insurance will probably pay. There may be a copay or not, depending on what insurance you have. And then for the uninsured, there'll continue to be access to treatment at least through December of 2024. And after that, we'll see what happens. So again, we have a very heterogeneous way of paying for healthcare in our country, and the answer, as always, is depends what kind of coverage you have, what kind of service you get.
I'm glad you brought up the healthcare, because I do want to touch on that next. One of the things that happened during the public health emergency declaration is that Medicaid had a continuous enrollment. And as a result of that, our uninsured rate in the United States fell to really historic lows of about 8% of our population not being insured at some level. And again, this was thanks to the expansion in the Medicaid enrollment and continuous enrollment. There's a lot of estimates coming out, particularly from Kaiser Family Foundation, about the number of uninsured will jump back up somewhere between 4 to 11 million more people in the United States with the ending of this declaration, and some other rollouts that are going to be ending soon. Let's talk for a moment about what that was like for us as a country to have such low uninsured rates.
Well, again, it was necessary because of COVID. People were going to the hospital, and it was really important. But the reality is that, we don't have healthcare insurance, healthcare access in our country. We're the only developed country that doesn't have universal access to healthcare. So we continue to have people that are not covered, and many states, including ours, doesn't have Medicaid expansion. So you have a significant number of uninsured. But what's going to happen with the end of the public health emergency? States were not able to kick people off Medicaid, and now they're going to be able to. So depending on that, the number of people that will become uninsured because they'll lose their Medicaid coverage, there are many estimates, but it's as high as 16 million, 20 million. So it's gonna be different. And again, that's it's bad. There's nothing that could be worse than not having healthcare coverage.
Yeah, absolutely. So before we talk about some of the lessons from the last 3 years, let's briefly touch on the future about some of the new variants that we have coming our way with COVID-19. We are seeing an increase in a variant called XBB.1.16. It's now estimated between 10 to 16% of all cases in the United States that are testing are this particular variant. I want to point out it's not doubling quite at the rate it was a couple of weeks ago, but what are your thoughts on this variant and what it might mean for us with another wave coming our way? Or what do you see as a prediction?
Well, this virus has continued to produce different variants and has continued to change, and the Omicron variants, I think, are a good example of that. After Omicron emerged, we're seeing a sort of a different varieties on Omicron, and we see how they emerge and how they become prevalent. The most prevalent one right now is this XBB.1.5, but we're also seeing this XBB.1.16 that is now about 12 to 15% of cases. So between those two, they make about 75% of the variants. And what happens is each one of these variants is, as it changes, it becomes more transmissible. It's more able to adapt to the respiratory epithelium. So the XBB.1.16 is about 1.2 times more transmissible than the previous variants, and it's not more severe, but it's more likely to be infectious. So what happens as a result of that is, I think many of us used to remember that you need to be with somebody for 15 minutes in order to get infected. Well, with this new variants that are a lot more transmissible, you may need only a couple minutes. An elevator ride may be more than enough. So the one thing to know is that we are going to still be seeing transmission, and transmission is not going to go away. And yes, we may see a surge, as long as you're still protected by the vaccines and by the immunological wall we have from prior infection and vaccination. We're not going to see an increase in hospitalizations and deaths, but that's why you need to be up to date. That's why you need to get your bivalent booster, whether you've been infected or not. Because if you do that, then when you get infected, it's going to be a nuisance, but it's not going to be something that is going to put you at a high risk. Now, if you are over the age of 60, over the age of 65, and you get infected, you should also get tested, and within 5 days, start antivirals, because, again, the antivirals are not there to be used because you have severe symptoms, but because you have the risk of developing a severe disease, and the biggest risk is dictated by age. So the variants are concerning as the virus continues to mutate, and we continue to see the virus change. But at this point in time, I think we need to also realize that they're not more severe, and therefore we don't need to be panicking. And yes, could there be a new variant? Could there be a new spike this summer? I think one I tell people that the most important thing I've learned with this virus is to say I don't know. We can't predict what's going to happen. So the answer to that is maybe. But the reality is, let's live where we are today and not worry that much about the future.
I think that's great advice. Let's talk about a consequence of having COVID-19, which is long COVID. And it's going by a lot of different names, but the estimates are close to 6% of the US population, adult population, now has long COVID, and upwards of 28% of people who've tested positive for COVID-19 have reported symptoms that are associated with long COVID-19. What do we need to do to make sure that we are both providing care and access for people who might have long COVID, and also for people to understand that this is a consequence, perhaps, of having COVID-19 infection?
Well, I think, first of all, long COVID is a really interesting manifestation. It's one that we still need a lot of research to be done to. We even need to, the National Academy of Science, Engineering, and Medicine has convened a panel just to try to come up with a definition. We don't have a lab test. We don't have a definition. What we know is that about 1 in about 13 adults in the US, which is about 7.5% of the US population, have long COVID symptoms. And that's being defined as symptoms that last more than 3 months after having COVID. And those most common symptoms are fatigue, headache, shortness of breath, cough. Who's more likely to get the symptoms? We're learning, but older people are more likely to have long COVID than younger people. Women are more likely than men to have long COVID, and we know that for example, Hispanics tend to have more long COVID than non-Hispanic whites or Black. So we're beginning to understand the epidemiologist disease. We need to understand the pathogenesis. It's probably not one disease, but it's multiple manifestations. And then we need to start doing clinical trials to see how do we get people better. The most important thing that we are doing, and most important thing the government has done, is that it established something called the Recover Cohort. And the Recover Cohort is a group of individuals nationwide with long COVID that are being studied intensively and are going to be followed, and also are going to be part of clinical trials trying to understand this disease and trying to treat this disease. And my advice to people is try to find a long COVID cohort near, a Recover cohort near where you live. And if here at Emory, we have one of those Recover cohorts, and sign up, get registered, because that's where the science is going to be. That's where the manifestations are going to be treated. That's where the disease is going to be understood better than in other places.
That's great. It's so important for us to try to figure out what is going on with people who are suffering from long COVID and the impact that it will have on our workforce and just people's lives.
Now, one thing that I do like to tell people, Jodie, is that among people who have had COVID, the percentage who have developed long COVID is declining. And again, we don't know if it's declining because the virus has changed or is declining because immunologically has changed. But if you look at you were more likely to get COVID back in 2020 or 2021. If you get COVID today in 2023, only about 10% of those that have COVID go on to having long COVID symptoms. That's very different than what we had before. So we are seeing a decrease in the risk of developing long COVID after infection. And again, it's something that we need to understand why. Is it the virus? Is it the immunological characteristics of the individual that is making that change? But clearly, there is a change, and the risk of long COVID today is not the risk of long COVID in 2020.
That is good news indeed. Let's spend our last few minutes talking about what we've learned the past 3 years in the United States. So the U.S. entered the pandemic with an underfunded and under-resourced public health system and with no pandemic playbook for preparedness. We also entered the pandemic with pretty unequal access to healthcare and unequal access to opportunities that lead to healthier lives in the United States. The pandemic certainly made these inequities more striking. And one of the things that has happened in the past 3 years is life expectancy in the United States has fallen by 2.7 years on average across the United States. But there are really large differences by race and ethnicity. These, by the way, are some of the lowest rates we've seen since 1996, and they are the most years in a row with life expectancy loss that we've seen in the past 100 years. So what do we need to do to change to make sure we don't see such tremendous loss when another epidemic occurs or another pandemic strikes or another huge wave of COVID-19 comes upon us?
Well, let me just start by saying that I'm very concerned that we go through these episodes in our country of panic and then neglect, right? We forget about things, and I'm concerned that we haven't learned the lessons, and we are not as prepared as we should be for the next pandemic. We don't have, our healthcare system is struggling right now. Hospitals are at capacity. There are people lining up in the EDs waiting for a bed. So if you have anything thrown into the healthcare system right now, like an epidemic of flu, you would have a problem. The healthcare system is at the brink. Healthcare workers are tired. There's burnout. And then the public health system is in significant problems, not only by funding, but also because public health has been attacked in a way that has made public health really vulnerable to basically, not recruiting the right people and not being ready for the next pandemic. So we have to support our public health system. We have to get the people to understand the importance of public health. Public health is about ensuring the health of the population. It's about preparedness. When public health is working, Jim Curran used to say all the time, and I love this, when public health is working, nothing happens. And that's what we need. We need things to be working well. We don't need to be seeing outbreaks of measles because public health is doing its job. It's vaccinating people. We don't need to see outbreaks of disease because public health is doing surveillance, is containing, is doing contact tracing, is stopping outbreaks. So we need to be on the public health needs to be in the front of outbreaks, not in the back end of outbreaks. And I'm concerned that we're still trying to play catch up. We're still not fully understand how public health is going to make us better as a nation. And that to me is a big concern. And as I said, the problem is public health is getting vilified, it's getting attacked, and quite frankly, in a very undeserving way. I have enormous respect for our colleagues at public health, our colleagues at CDC, at the state and local health departments. They've done a yeoman's job during the pandemic, and they continue to do a yeoman's job. Then the first pandemic, then monkeypox, and then all the things in between. And they are in the forefront, and they're not, they're not taking days off. They're working to try to keep the population safe. So let's all support public health, and let's start blaming public health for what's wrong, because we are going to be better off if we have a strong public health when the next pandemic comes. The next pandemic is not if it comes. The question is when will it occur? And it's going to be, it's going to be here one of these days. And I'm very concerned right now, multiple things, but the one that worries me the most is avian influenza. Avian influenza could really be a significant problem.
No one wants to hear that, but I do certainly agree with you about the incredible work that's been done in the public health arena during the last 3 years, and the really hard time that people have had working in that space and in healthcare systems for sure. Did you ever think that we would be sitting here talking about this pandemic still in 2023, and that we would have 1.1 million people in the United States who've lost their lives to COVID-19 in the past 3 years?
I think the short answer to that is no. I remember back in March or April of 2020 having a conversation. I had a phone call, many that I had with Dr. Fauci, and I said, Tony, how many people do you think are going to die? The president's talking about 20,000 Americans, 10 to 20. What do you think? He said, it's going to be somewhere in the neighborhood of 50 to 60,000 Americans. And that sounded like a huge number. I think if back in March or April of 2020, somebody has said over 1 million Americans are going to die as a result of this pandemic, I think that person, you would have been called crazy. You would have been said, you don't know what you're talking about. The reality is the U.S. has had one of the highest mortalities of any country. We have a very high excess mortality, which are deaths not only from COVID, but other deaths occurred during COVID. And that is something that, the disparities have been stark. So at the end of the day, I think that what the pandemic also teaches us is the importance of addressing health disparities. We need to put an end to health equity, but we need to do it. We need to put an end to health inequities, and we need to take that seriously. We talk a lot about health disparities, health inequity, but I'm not seeing anything that is changing that gap. As recent as yesterday, I was reading a piece in the New England Journal of Medicine looking at access to treatment for opioid use disorder and access to medications for opioid use disorder, and showing very clearly enormous racial and ethnic disparities in access to therapy. And more concerning is that over the 5 years they looked at, there was no difference, no change. That didn't get better. So I hope that we can really, as a nation, start addressing this, and we need to address it by really focusing on two things. We need to focus on making access to care for everybody, but also we need to focus on really addressing the social determinants of health. The health disparities are because the enormous social disparities that we have. So we need to have a more equal society if we're going to be confronting a pandemic in a better place.
Yes, yes, I agree with you completely. As we wrap up the end of the public health emergency declaration, I just want to make the point that this does not mean that the COVID-19 pandemic is over. It does not mean that the virus has just gone away. I also think some people will be surprised that the public health emergency did not end prior to today, because we have not talked about it a lot. What are your last thoughts about how we should be learning to live with COVID what this will mean for us in the next couple months and moving forward. And is this now just another non-seasonal, but hopefully someday seasonal infection that we are going to be living with?
Yeah, I think so. I think we just need to incorporate it into the transmissible infections we deal with, whether it's influenza or norovirus or other outbreaks that we see regularly. And we need to think about it that way, and we need to not make it. There should not be a COVID exceptionalism, but we need to treat it like we treat many other things. But we need to also, allow that people have. There are two things that I think are going to be very important, Jodie. Is number one, as I said, access to care, but number two is ability to not come to work when you're ill, sick days, and be able to do more Zoom work and distance working. Because I think before the pandemic, I'm sure you did it. I certainly did it. I came to work with flu and feeling terrible and respiratory viruses, and I'm sure I infected other individuals. That, I think, one lesson out of the pandemic is we shouldn't do that. So if you're sick, you should be able to stay home. We need to have paid sick leave in our country as a way to prevent spread of infections in the workplace. We need to have better access to daycare, so people the kids can be taken care of when the parents are at work. And we need to really ensure the social support necessary to confront this kind of issues. I think that's going to be very, very important. The last thing I want to say is I really want to give a big shout out to my Emory colleagues. When I think about what people at Emory have done, what you have done through communications, what you've done through the COVID response, working with underserved communities, vaccination, testing, what colleagues and the hospitals have done, taking care of patients, vaccinating. I mean, you name it. Emory Healthcare, Grady. I mean, everybody within the Emory family that works in healthcare or in public health has really raised up to the top. We did vaccine trials. We were the first ones to. We did the phase 1 studies with the Moderna vaccine. We contribute to major trials in treatment. I go on and think about the incredible work done by Emory, and that's one thing I feel very proud of. Emory raised, people responded, and Emory really raised to the top. And I think the response of Emory has been second to none. And I think it's a great example of what a wonderful community we have. So as this public health emergency ends, what I feel like saying is thank you to the Emory community for having had such incredible response.
Thank you for that. I wholeheartedly agree with you. And I think that those of us who have worked in this outbreak, it was a privilege to be able to use our skills to do so. And I am also incredibly proud of how Emory has risen to the occasion, and will continue to do so. So, Dr. Del Rio, you have been a phenomenal source of sound and straightforward and consistent information about the COVID-19 pandemic and what people need to hear. So thank you to you as well. And thank you for being with me here today as we mark this historic moment with the end of the public health emergency declaration. Although, to be clear again, this is not the end of COVID-19, but it is the end of a lot of different ways that we're going to see funding funneled into the pandemic response. And as we hit this new relationship with COVID moving forward. Thank you so much, Dr. Del Rio, as always.
Happy to be with you.